pleasure to have you with us, Stuart. So you are urology nurse practitioner in the Western District Health Service, primary and preventative health in Australia, down under. And you have more than 20 years of experience in intensive care, emergency and community health, especially rural men's health and urology. So we are very curious to hear from you, your perspective. I took a look at your talk before. I'm really curious to see what you're going to share. And then afterwards, the two of us will have a chit-chat what we think could be translatable and transferable to Germany. Stuart.
Thank you very much for the invitation. I look forward to having a chat with you after. But I must say I've been quite impressed with what I've heard so far at the conference, and I do thank everybody. I do apologise for my ability to not speak German, but I certainly will do my best to hopefully put some context to my presentation in the German language as well. So, as we've said, I'm a nurse practitioner in Hamilton, Western Victoria. I will show a map in a minute. But my session aims today is to actually hopefully open up a little bit more dialogue with regards to what we do in Australia, down under, as you say. I'm going to probably highlight quite a few aspects of world healthcare, certainly care in terms of the US and the UK, and certainly highlight where we've come from and where we've shifted to in terms of bringing, as you've said quite eloquently, bringing nurses to the table. And I do understand we're in a different country, but we certainly have embraced the role of nurses and brought them to the table, and we are a respected entity, and certainly we've seen some great advances in our nursing care. I will focus also on the community-based focus, and I do know that you are sort of very focused on primary care and preventative care and obviously community-based care, so I'll try and sort of expand a little bit on that, on what we do in Australia as well. I'll talk first of all about some demographics. As you can see, Australia's a big place. It's a very big place. And as you can see, Germany and the whole of Europe fits inside Australia. You're welcome to come over and see us anytime you like. But as you can see, there's a massive difference in our population. You have around about 90 million. We have about 30 million. We only have around about 4 people per square kilometre, whereas you have about 240. So that's a big difference. And you're a very concentrated country, whereas we're very sparse. And we also have a very much a rural and regional context to our culture here. So the tyranny of distance is very evident. So I always ask people, when people ask me whenever I'm traveling, is it safe to visit Australia? Well, it is. We do have some little critters that do kill us, unfortunately, but we also, we respect them, the snakes down the bottom and the redback spiders. I have them on my farm at home, but as long as I don't bother them, they don't bother me. We do have the cute and cuddly, obviously the kangaroos and the koalas, you see. This picture on the top left is actually my emergency department at the hospital I work with, and as you can see, we occasionally get visitors. So we have koalas come through, and this is a wallaby as well that comes through. They're very harmless. They just get lost in the city sometimes and come to the emergency department for a little bit of friendship. So it is safe. Don't worry what other people tell you. It's a great place to live. We'll talk about some of the population and our density. And as you can see in Australia, most of our population is based in the outer sort of coastal regions. And you can see the whole of Australia has most of its population in the outer areas. You can see Victoria, that's where I'm based, down the bottom of the screen. And you can see that I live in Hamilton and I own a small farm around Hamilton. We're about 3.5 hours travel by car to our major tertiary centre, which is in Geelong and Melbourne, which, as you can see there in the dark red. The big thing that we do see now is our workforce is around about 450,000 RNs and midwives, and you can see that in Germany you're sitting at around about 1.7 million, and we can see that around about 600,000 of those are in aged care, which is quite interesting because that's where a lot of our primary care and community-based care focus actually occurs, particularly in Australia. What we see in terms of global impacts, and I think we've all seen the global impacts post-COVID-19, it triggered growth in a lot of areas, but it also triggered a lot of other factors. And I think no doubt Germany would have seen these as well. In particular, healthcare workers shortage and burnout. That's a big one, and certainly a big factor in Australia as well. And certainly the research shows that any country nowadays has a major implication of worker burnout and not being able to access the right numbers of healthcare workers. So we've seen some great changes in terms of healthcare spending and investment. We've seen obviously some scientific advancements, and I think we're going to see a big impact of AI. It's not going to affect my work, I can't, but certainly I think we'll see a great deal of AI in community-based interventions and promotion, in particular health promotion. Alternative care methods have really sort of rocked on here, but certainly that is a factor. But probably what we're seeing also is the mental health factors and well-being are being affected. And there's a lot of issues in terms of microcultures and politics, energy crisis, climate change. They're all affecting our ability to deliver healthcare to the community. And when I was talking to Robert about this presentation, there was a lot of focus on what is happening in Germany and the focus about how we actually expand our care to a community base or a primary care. We call it primary and preventive health or community-based nursing, and whether Germany can move into that role model as well. Now, I know there's probably some medical practitioners in the room, so I don't want to offend, but the idea that doctors can do it all is ending. It's gone, it's finished. And we know that because doctors seriously cannot keep up with it. And the statistics there in terms of the Maslow burnout inventory shows that unfortunately, this is actually quite old. This is 2016, but 40% of anaesthetists, 40% of urologists, 49% of German doctors are all showing significant burnout and unfortunately suffering at the hands of the demands of healthcare. Probably one of the big concerns that I see for Germany is you're going to lose around about 8,000 general practices in the next 3 years, 2 to 3 years. So when they close, you're going to see an increased demand on your acute settings, so your emergency departments and your acute hospitals in delivering just primary care, and that's the care that general practices often provide. And I've seen a big change in the practice that I work in. I work in a general practice and I'm quite accepted by the general practitioners as a nurse practitioner. But we used to have 24 GPs full-time and we're down to about 6. And that's a significant change. And there is no easy answer. And unfortunately, if you had a German medical conference, I think you would see the same rhetoric being presented there, that the burnout levels, the levels of depression, the level of alcohol abuse, substance abuse, productivity is all being affected by the time that we have now, where doctors unfortunately can't do it all. That took a long time in Australia, and we're probably a little bit more advanced than Germany in terms of working towards how do we actually fill that gap, and that's where I will talk about nurse practitioners along the way here. What we see in the now I can change this slide to be the seesaw of any healthcare system, and that is that we've got burnout, we've got medical and nursing shortages, we've got increased cost of healthcare delivery that's happening worldwide, and we've got an increased level of chronic diseases. Now, the other end of the seesaw is that, there's great advances in medicine, there's great advances in nursing care, and I know that Germany has a leading world economy, and it's very forward thinking. And even the fact that you're having this conversation today about what can we do to enhance nurses' roles and bring them to the table, enhance community care and primary care function, is evidence that you're actually already moving in the right direction. So I do congratulate you on that, which is fantastic. I think the entity that we always talk about is a different country, but the same problem. And as you can see, I only just searched on my Google Drive, and I, just found out how many, nurses does Germany need versus how many nurses is Australia going to need. And you're going to require about 500,000 health professionals by the year 2030. I don't know where you're going to get them from, because we can't get even 85,000, and for you guys to get 500,000 is going to be very significant burden upon your government and health system. You've got 5 million Germans will require long-term care, and that is going to be a big factor that's going to affect where do you get nurses to look after patients in long-term care. And the big factor is, how do you keep them out of long-term care? Because that is the role of preventative health, and that's the role of community-based nursing. I think you're probably the same. You can see by the lack of hair that I have, I'm not as young as I used to be, nor are probably many of you in the room. And that we see the fact that 40% of German nurses are over 50 years of age. I am, even though I don't look it. And we are looking at retirement in the next 10 years. I'm looking at about retirement in the next 5 if I can. So that is another big factor that we do have. I can tell you that in Australia, we have around about 30% of our nursing and allied health professionals imports. I don't mean that in a negative fashion, but majority of our nursing population now is being recruited from India and other countries, and they are very willing to work in our aged care and community base and our acute care sectors, but that is not a endless tap that we can tap into. So I can see that Germany will have a similar problem in finding nurses to actually fill those gaps in healthcare. So I just want to highlight the difference between and the similarities between the German healthcare system and the Australian health system. So we have a Medicare system, and Medicare stands for medical care for any patient. So if you're public or private, you will still get Medicare coverage, which means if you get ill, sick, unwell, you will get care within one of our hospitals. It'll be a public hospital. If you are well off enough, and similar to Germany, if you qualify, you can take out private health insurance, and then we'd have a range of private hospitals which will support the care for that. But then there's an increased fee paid to the surgeon, doctor, or specialist that cares for you. Medicare is funded by all Australians. We have a 1% levy on our income, which actually pays for the health care for all. And most of the time we will do bulk billing. So when I'm in a clinic, I can pick and choose who I bulk bill, or if I assume that they have the means to pay for that consultation, then they may get a fee for service as well. So it's very similar to Germany. One big difference that we see in Australia is that we have a national regulatory board, and that's called APRA or APRA. And this is a very interesting area, because it doesn't matter whether you're an anaesthetist, a doctor, a dentist, an optometrist, an osteopath, podiatrist, or Chinese medicine practitioner. All of us are registered and endorsed under the APRA registration model. So I cannot work without an APRA registration. It is a means by which you can check on my registration. You can check if I have any notations against me, or if I have any claims against me, and whether I am licensed to practice as a nurse practitioner. And every medical or paramedicine, anyone who's involved in healthcare delivery, is linked to that. And that is an excellent way to legislate and to monitor what actual health care is being delivered to the population. And I do see that in other countries, they may not have that. And that does open up a little bit of problem as to who is looking after who, and are they registered and endorsed and legitimised about doing the treatment that they're actually providing. So I want to move on to acute nursing roles and see where we go from there in terms of Australia. So you can excuse some of my German in there, but my Google Translate did help me through there. So we have nurses' aides, which are just people who come in and assist with nursing tasks. They have a TAFE, or a undergraduate qualification. We move to enrolled nurses, which do a 2-year qualification course. And then majority of our nurses are what we call registered nurses. They work in a band of being registered, and their pay goes up over 8 years. And once they get to that 8 years, they can choose to stay as that registered nurse, or they can specialise, or they could stay as a clinical nurse specialist. Clinical nurse specialist just means a nurse that's been in the field for about 5 years and have been deemed to be very competent in that area. Lots of nurses will choose to go into a management role, so we call them a associate nurse unit manager or a nurse unit manager. Now, that's in the acute setting, okay? We still have nurses who choose to move out of nursing and may become educators. There are nurse educators. And then we have two lower cases there, which we'll highlight a little bit more specifically, and that is our registered midwives. And our registered midwives actually have the ability to prescribe. They're mainly prescribing oxytocin, certainly the medications involved in following the birth of a child, but they do have a level of prescribing rights in the hospital. And our obstetricians are very supportive of that. They understand that most of the registered midwives deliver the child anyway, and the obstetrician just simply comes along to collect the glory. And then at last, we have nurse practitioners. Okay, and I spoke to Robert about nurse practitioners. These nurse practitioners will have a master's qualification. They usually have had at least 10 years experience in their field of choice, and they have to undergo a form of registration and endorsement. So they have to have a legitimate position, and that registration of nurse practitioners is a legal documented name. So it's a title that is legalised in Australia. Okay. We also have some community-based nursing roles, and as you can see there, they range from enrolled nurses right through to nurse practitioners once again. And these nurses are working in community-based settings. Now, one difference that we have in Australia is that we do not discriminate between community-based nursing and acute care. So every hospital that you see in Australia will have a community-based nursing division. And so if you go to one of our major hospitals in one of the capital cities, they'll also have a community nursing division, and they will provide the community-based care when a patient is either pre-admitted or post-discharge from acute sector. So we adopt this quite well, and this is actually very much supported by our government in that they see that the value of community-based nursing is a real entity in terms of delivering care for patients, one, to prevent them coming into hospital, and number two, to actually support them after discharge from hospital. And so this is very well supported by our medical fraternity as well. They very much see the benefit associated with community-based nursing, and they're very supportive in that. And I'm going to highlight a few of those roles that we actually do within that. So what are the drivers for community health? One is trying to keep the patients in the home, keep the patients out of acute care, and we try and deliver as much care for that patient in the home base because it's an early opportunity to intervene. And hopefully, if we can keep a patient out of the hospital, it saves the healthcare dollar and also improves the patient's well-being and keeps them in the home. So it's certainly a process where we focus on preventative health as our most important factor within the healthcare journey. Some of our examples of healthcare in the home: district nursing services. It's either pre or post hospitalisation. So many patients will have a district nurse visit them on a weekly or a daily basis to provide care in the home. This is very strongly linked to our medical practitioners, and our medical practitioners support this quite well. And they actually see the value in actually preventing this patient from actually coming into hospital. Because as good as hospitals are, you bring a patient like this in the picture to hospital, the chances of the patient not going home is very real. And so there's certainly something that we prevent and we certainly promote within our community division. Medication delivery, opiates, IV therapy, all delivered in the home and certainly is supported by our specialised nurses who work in the community or district nursing field. Another area of support that we provide to our patients before hospital is our hospital admission risk program. So these are patients that are recognised that they have a risk of coming into hospital. It's a free program. It's a multidisciplinary process where we actually have a good connection with the acute sector, with the doctors, with our GPs, and we're working quite strongly to actually keep patients in the home. And it works very well so that we flag these patients so they can be seen by their GP in order to prevent them being admitted. We've now moved also to what we call CHISP or HIF, which is chemotherapy in the home. This is certainly reducing the risk of patients who are immunocompromised coming into hospital. And much of our immunotherapy or our chemotherapy is delivered in the home. And it's a fantastic opportunity for patients to have their care and their treatment delivered in the home base. Another big area that we deliver is diabetes education. Obviously, it's education. We want to prevent admission. We want to obviously strive to patients being able to receive their medications and treatments at home. And this is an area where nurse practitioners will excel in Australia, and certainly that's a developing trend at the moment where patients simply have a call to the nurse practitioner, they'll come around, they'll deliver their medication or they'll give them advice, change their dosages, and will prevent an admission or an adverse event. We also have continence stomal therapy. Palliative care is another area that we have where most patients, if we can, will deliver the palliative care in the home base rather than actually have the patient being admitted for end-of-life care. And it's something that we really focus upon to actually prevent patients being admitted for the end-of-life care. So I want to move on to the history of nurse practitioners in Australia, and I will compare that with the UK and the US. The concept of a nurse practitioner was developed in about 1990. The first were endorsed in about 2000. In 2010, the title was protected under legislation. And that just stopped other nurses choosing to say, well, I'm an advanced nurse practitioner, or I'm a nurse that I've been working 5 years in a specialist area, I should be a nurse practitioner. So the title is protected, so therefore you have to go under a registration body to actually practice as a nurse practitioner. Initially, we've sort of focused on defined scope of practices. So in my time, I was endorsed in 2006. I was in men's health and urology. I've added to my scope of practice cystoscopies. I perform flexible cystoscopies. I have dermatology, and I deal with younger people with mental health issues as well. The benefit associated with nurse practitioners is that we have access to that MBS or Medicare scheme, so we're able to bill for our time, particularly when we work in community-based. You don't necessarily able to claim anything in the acute sector, like a public hospital, because that's already paid for by the medical or Medicare benefits. But if I see a patient out in the community, I can charge that patient a bulk bill fee for the services that I deliver. And that fee goes to my hospital as part of the income that I generate. So nurse practitioners in the UK is a bit different. They've been around for a long time. For the United States, since the 1960s, they've got a master's or a doctorate degree. They've got board certification yet again, and that is a really important factor. We need to be understanding that board certification or legislation to protect that title so that nobody else can be called a nurse practitioner or function as a nurse practitioner without going through the certification process. The nurse practitioners in the US act initially in a restricted fashion and then go to full practice. They're very much endorsed by the medical fraternity, and they've gone through that journey where there was initial barrier to it, and now the GPs and the medical fraternity have sort of said, we need their help, we have to use them. That's absolutely fine. There's about 385,000 nurse practitioners in America. The UK has the equivalent, and I think this is some way that you're looking to go with the advanced practice nurse or the advanced nurse practitioner title. Theirs is not legally protected. They still have to have a master's qualification or at least 3 years experience in a specialist field, and then they can gain some specialist prescribing licenses. So some of the roles that I have or that we see for nurse practitioners in Australia, general practice, we work a lot in general practice. We work in intensive care. We also work in a lot of urgent or non-urgent care clinics, and that's taking the pressure off our emergency departments. Our emergency departments are absolutely pushed to the nth degree, primarily because our GP clinics aren't able to provide services to general patients. So now we have non-urgent clinics, and nurse practitioners excel in that. So they will simply man that clinic and provide prescriptions, referrals, x-rays, ultrasounds, etc. in that area. That's me down the bottom. I'm doing a cystoscopy on a patient there, and I work in the acute sector in surgery as well. So as you can see, We have a registered body as well. We have the Australian College of Nurse Practitioners. And as you can see on the right, there are our professional standards. We've now moved away from being a specialist stream to actually sort of providing care under those 5 bodies there, which will allow nurses to choose which area, whether they want to be in primary care, whether they want to be in acute, whether they want to be in child, or whether they want to be in mental health. Okay. So how do I work as a nurse practitioner in community? Look, I have a fairly wide and varied job. I work in Hamilton, Western Victoria. That's a couple of pictures. That's my farm up the top there. We've got about 30,000 square kilometres. And I work basically in a community and a hospital role. Initially, when I went to be endorsed as a nurse practitioner, I had great blockage from the GPs. I had blockage from my hospital. I had blockage from the Director of Medical Services and a lot of specialists until they saw the value of the role and that I wasn't wanting to be a doctor. And that's the biggest barrier that many countries have, is that the medical fraternity think that we all want to be doctors. There is nothing further from the truth that I want to be. I do not want to be a doctor, but I do want to have the ability to use my skills to the best degree that I can. And being able to prescribe, being able to order tests, being able to diagnose and work collaboratively with the medical fraternity works fantastically. In actual fact, I'm in the rooms of my urologist right now. I'm in his house and I'm doing this presentation to you. We work collaboratively. We travel overseas and deliver aid, and he values my role, particularly in what I deliver for him in Hamilton. So nurse practitioner in general practice, the way I work in general practitioner, I work a couple of days a week. I do clinical consultations. I have an MBS item numbers, which I can claim under. Most of my item numbers are time-based. So if I see a patient for 20 minutes, I can claim $47. If I see a patient for 30 minutes, I can claim $57. That's all bulk billed. So the patient doesn't pay anything. It comes out of Medicare. My clinic is a men's health clinic or dermatology, urology, mental health, or just general practice. And I don't see kids as such, but I see younger men and younger boys and girls for mental health issues, and I do prescribe for those patients. My other practice that I work in is for urological practice. It's based in Warrnambool, which is about an hour away. I just simply travel there and consult for a day. I run a penile rehab and a PSA monitoring clinic. Okay, so I see public and private patients. Once again, it's MBS funded. And I also go through the process of arranging surgical consents, bookings, case management, procedures, all for those patients which are rebatable. A lot of my work is involved in inpatient care, so a lot of it's in surgery, but it's also in emergency. As I said, I'm a nurse cystoscopist, so I do probably about 400 to 500 cystoscopies per year on patients looking for surveillance, bladder tumours, or investigation of lower urinary tract symptoms, and that includes management with BCG therapy, which is intrathecal botulism or tuberculosis for management of bladder cancers. We have surgery that I work in twice a month, and on those weekends that we do surgery, I'm on call and offer an after hours service for any patients that remain in the hospital post TERPs or biopsies or bladder cancer removal, etc. And that's a fantastic service because you're working probably at the level of a registrar. And that is an important process because many of our registrars, even though we're a training hospital, have never done specialised urological practice. So it certainly helps with that process as well. The other thing that I do is outreach clinics. I run a men's health clinic in sort of areas about an hour to an hour and a half away. And the reason why I do that is there's small populations there of maybe 1,000 people, 5,000 people, and we don't have any GPs go there. A GP a service that provides to outreach areas or to smaller towns is just simply gone. It's dried up. We don't have any GPs. So this is a real opportunity for nurse practitioners. And so I run clinics out there, and I'll just run a clinic once a month in each area to provide services for any patients that work in rural or remote areas. And as I showed you on the map, Australia's a big place and GPs just simply don't travel out to the outback area. I do a lot of community education in schools, health promotion activities, and do a lot of vaccination and screening programs as such. So to finish up, I just want to highlight where to from here. And I'm hoping that we do get a few questions from the audience about this, but preventative health promotion is not a long-term project. Governments don't like it. And I know we might have some government representatives in the room here today, but there isn't a great deal of bang for your buck. And what I mean by that is you don't see any great outcomes associated with that in the short term. So if you've got a government that's in for 3 years and they say, let's do a diabetes education program, or let's do some health promotion to stop falls, or let's do some alcohol health promotion in schools, you don't see the benefit associated with that intervention for many years to come, but you will see that. But this is a problem that we do have with governments because they change quite regularly. They want to see quick reactions, and so that's why acute healthcare seems to come on their radar of providing more funding for it. The other big thing that I want to finish up on is that medicine cannot keep up with modern healthcare needs in a country. So in a country the size of Germany, you are actually going to lose a lot of GP clinics, and that is an opportunity for nurses or certainly community-based roles to step up and take up some of that care role. And I do hope that you're going to see that expand in your role as such. Expanding sharing as responsibility is an option. And the other thing I really want to highlight, that second last point, is that nurse practitioners, we don't want to be doctors. We seriously do not want to be doctors. We just simply, sorry, that's my timer for 30 minutes. We don't want to be doctors. We just simply want to be able to care for our patients and work within our scope of practice and to a proficient level. And nurse practitioners is certainly showing that way in Australia, and we're very much accepted by the medical fraternity now. We weren't, but we are now. Certainly we can ease the burden safely and efficiently, and I would certainly like to say thank you very much for your opportunity to present here today, and I do hope that I've given you some insight into the process that we run in Australia. I would encourage anyone who would like to come and visit. We would welcome you with open arms, and thank you very much for listening to me today.